as per Cap 253B of the laws of Kenya. And now he is the chair of the KNDI. Ladies and gentlemen, let's put our hands together as we welcome Professor NGUKA for his keynote speech. Is the chair-elect KNDI. Professor NGUKA, please.
Thank you, Dr. Mogesi. We always tease ourselves, Kaki. Thank you. And welcome, Martha. Thank you. I was missing you. Yeah. But now I've seen you. At least my day is made. Ladies and gentlemen, we have been having almost 4 days conference. And it has been focused on health systems strengthening. And we had intentions with this component to be able to just educate. Let me not use the word education, because when Dr. Keo talked of educating some of our members of government, they took offense. Why do you want to educate them? And they thought they're educated enough. But we always say that education has no end. We keep on learning every day. Whether that is acceptable in the government world, we don't know. But it almost brought us problems when Dr. Keo talked about education. But today, I would like us to go through how we link nutrition and dietetics to health systems strengthening, and especially integrating nutrition as a profession, nutrition as a practice, and nutrition as a science in strengthening the issues of health systems. And we are concerned about this because we have seen, and from the papers that were presented here for the entire 4 days, you realize the key roles that actually nutrition and dietetics play in strengthening health systems. However, up to date, we are still struggling to convince even the government system that, you need nutrition and dietetics professionals in your system to continue strengthening the health systems. You will realize that health systems, as it were, has 6 pillars, which involves the issues of governance, the health workforce, information systems, financing of products, and service delivery, and all this required to be integrated into the health systems. You agree with me that the goals of strengthening health systems is basically to make it resilient and to help in achieving the universal health coverage, which is actually has been the goal of our government, and even to provide equitable quality care for the entire population, with nutrition and dietetics playing very critical role in ensuring that it's achieved wholesomely. Therefore, we agree together that mainstreaming nutrition and dietetics issues in healthcare systems ensures efficiency and effectiveness in achieving the universal health coverage. Therefore, in this keynote address, I'm going to highlight the typical interlinks between the blocks as identified of those health systems, the 6 of them, in relation to nutrition and dietetics service. Let's begin with the declarations that the United Nations had way back in 2019, or earlier than that. The United Nations declared that universal health coverage was recognized as a primary healthcare, or recognized the primary healthcare as the most inclusive, effective, and efficient, wholesome of society approach to ensuring that people's physical and mental health and social well-being are catered for. And this is a declaration that has been with us for many years. Further, that declaration, if you go through it, it also states that fundamentals role of healthy diets and healthy nutrition play equitable and sustainable food systems. They play along in strengthening the health systems. And therefore, the role that nutrition and dietetics play in strengthening health systems can never be downplayed. Let's just check on how now nutrition and dietetics specific help in strengthening health systems. The case for including nutrition as an integral component of primary healthcare is compelling for the following reasons. One, for decades, health systems and clinicians have focused on the medical drug treatment-based model of disease that ignores fundamental causes such as diet and even lifestyle. The consequences, therefore, are dire. And today, we started with single threats, then we moved to double threats, and today we are talking about triple threat. And it's because of that which has not been taken care of within our healthcare systems. In fact, that even complements the issue of governance. You remember the other day we were talking about the nutrition unit having been downgraded from division to actually a unit in the Kenya government system. And if you look at CAP 253B, it was postulated that we have a Directorate of Nutrition Services, basically to form as a department in the health systems in Kenya. However, that was never to be. And today we have a Director of Nutrition Services reporting to another director. A very interesting scenario. So I can pass it in the meantime. We'll still talk about it. As governments and policymakers increasingly recognize this depth and breadth of nutrition burden, we are compelled to act in both as professionals and even as government. So integrating nutrition and dietetics actions into health systems to promote healthier eating and prevent and treat undernutrition and diet-related chronic diseases could generate substantial health gains. And as Dr. Yunga had put it, will be highly cost effective. We don't know how long it takes, because I know even from the researches that were done on Monday, the people in the profession have estimated the cost benefit of actually doing nutrition interventions. But it seems government is still not listening. There is increased recognition that key stakeholders, including government and private sector, are accountable to healthier and most equitable food and health systems in the communities that they serve. This means that as a people, we no longer want to leave this problem to individuals, because I think at some points, maybe government thinks that persons within their jurisdiction have a responsibility to take care of their nutrition services. They don't recognize that as a profession and even as governments, we have a responsibility and a role to ensure that the nutritional status of the individuals within our jurisdiction is our responsibility. And that statement gives the fact that that role has to be played by the government and not the individuals themselves in ensuring that within the context of health system strengthening, the services are delivered equitably and equally within the community health strategy. So we agree that in population or community health promotion, population-based interventions can reach broader segments of society, require less individual efforts, and can be less costly compared with individual-based approaches. Such as the upstream and actually promote government's bottom-up approach, as has already been alluded to even by our politicians. So these are very useful in strengthening management of various conditions that are as a result of nutrition, particularly the non-communicable diseases management, while policies and programs were created over decades to address hunger and food security. Far less was known about how to improve diet quality and address diet-related community diseases. And today, we all have this in our documentation in the form of research, which just need to be picked up by the various government and stakeholders and be used in ensuring that these are incorporated in the management. I now know maybe in the Ministry of Health, we have a policy on, it's actually a guideline for clinical management. But if you look at what is online, it's actually 2010. Myself and Mugezi here and the team, we have been working on a document that I have not seen. In fact, I was trying to check what is really happening. Dr. Mugezi, I'm not asking you, but the reality is we are still having, for the clinical nutrition management, if you look at what is online, it is actually the 2010 one. But I know that we have worked on a new one. Whether it has been used or not, we don't know. So God knows, because we have a new one. But what we have there is 2010. So recent advances and efforts in nutrition policies to prevent non-communicable diseases should inform the current priority areas and contribute to the development of universal health coverage and address the diet-related diseases. Because we know it is there. Why must we have 15 years down the line and we have worked on a document that should be useful? Consensus that has been built is that ensuring equitable access to effective nutrition intervention within the health system can play a pivotal role in improving diets, preventing and treating diseases, reducing healthcare costs, and ultimately improving everyone's health, ensuring that no one is left behind. However, these justifications are not yet matched by the robust approach that unites nutrition and dietetics and healthcare in terms of equitable policy, financing, monitoring, and evaluation in Kenya particularly. So nutrition and dietetics services are frequently under-prioritized in the national healthcare policy and in financing decisions. And as we talk, if you look at the national budget, actually some of us said it is zero budget to the nutrition department. And you wonder why. With all the NGOs that are working on this, government is still not yet able to see the priority of nutrition and dietetics as a component. If you look at the Global Nutrition Report, the current Global Nutrition Report highlights the need to integrate nutrition and dietetics into the universal health coverage as an indispensable, and I repeat, indispensable prerequisite for improving diets, saving lives, and reducing healthcare spending, while ensuring that no one is left behind. So we are not a supplementary service. We are actually a key service of health. And somebody cannot say support service. Without this, there is no health care. And I would like you to present, please, our IT, go to the design in the integration of nutrition and dietetics. Yes, that one. So in that design, I've intentionally tried, because I was imagining government may not understand how to integrate this into health systems. And this I picked from the Nutrition Global Report. So if you look at it, it is indicating very clearly, and if you can expand it, I don't know whether people are able to see it. You can see it. So that is actually integrating nutrition and dietetics services into the health system strengthening, and beginning with governance. And this one I've already talked about. First and foremost, we are proposing that we streamline governance of nutrition and dietetics leadership in the Ministry of Health. Nutrition will only serve best when it is given its own department. And full integration of nutrition care into the control of healthcare sector, not for one cadre, not just medical doctors, and it can never be just for nurses. The healthcare is so big to be left for one cadre. And this, in that component of governance, we are saying that nutrition and dietetics is a directorate as per the law. And that needs to be implemented in the first place. It's not a policy, it's just an implementation need. It is already recommended that we have Directorate of Nutrition Services and that it is in the Act. And if somebody is failing to know, in Cap 253B, it is there and it is envisaged. So all we need is that the ministry to implement that so that we are not a unit within another department. On the healthcare workforce, nutrition and dietetics has a number of staff which we think can go beyond, even up to level 1, all the way from level 1 to level 6 hospitals. There is no need of having a dispensary without a nutritionist in Kenya. We want to believe that all healthcare facilities should have Department of Nutrition Sciences. Even to be able to support the so-called community health promoters, you need a nutritionist to give correct information that will be carried by the community health promoters to the various units in the households that they serve. Otherwise, you will not pretend that the nurse or a public health officer will give correct information. That is on the human resource for health. On the healthcare financing, we have talked about this, and I want to range it from products in the healthcare systems and even service costing. SHA, for example, the Social Health Authority, has not costed nutrition services, including nutrition products. And that ties together with the products that we require and the medicines in nutrition. We must appreciate, and I've always told medics and pharmacists, 3/4 of what they call medicine are actually nutrition products. When you talk of Neurobion, that is vitamins, isn't it? You talk of cyanocobalamin or the vitamin B12, it's an injectable, it's within the treatment cadres. If you look at enzyme CoQ10, we use it for treatment of conditions. All these are nutrition products. So why do we purport not to be charging products that we give and services in SHA? The running call here is that SHA must be reviewed to include nutrition products in it. So that is under the healthcare financing. We also want a dedicated budget for nutrition services from the National Treasury as an expenditure line in healthcare financing. That will contribute to nutrition helping and integrated in strengthening health systems in Kenya. If you continue with that, we have the next pillar, which is access to essential medicines. The nutrition treatment products are there, and Dr. Yunga has just been talking about vitamin A, which has been supplemented since 1992. And to date, we still don't have this integrated into our systems properly, other than those, I can call them the supplementations. Now we should make it routine. And that's what Dr. Martha and colleague has been talking about, routinization. And this will then contribute to health system strengthening. In addition to that, if we go to the other sections of health service delivery, nutrition is a well-orchestrated nutrition and dietetics professionals. We have highly skilled and highly trained professionals in the area. And in terms of service delivery, we are capable of doing this. Today, Dr. Keo, we have registered up to 14,500 nutritionists in Kenya. in terms of the global requirements, we know that nutrition is supposed to serve at a ratio or between 1,000 per 100,000. Let me say, if you look at Kenya, each nutritionist now is serving up to 4,000 staff, because we are at about 50 million, although we are more than that. We are each nutritionist here, which is supposed to serve maximally about, if community health units are serving up to how many units household? 10 households, isn't it? Now, nutritionists are supposed to maximally 100. And in facilities, I think just like doctors, the Nini is the same. The ratio is the same. For you to be able to give clear service or quality service to the population. Today, we are talking about 14,500 registered nutritionists with a population of 50 million or over 50 million Kenyans. That is over 4,000 Kenyans per nutritionist. How do you give that service? Of the over 8,000 active nutritionists, only 20% of whom find themselves into the requirement. Yet, this is a needed service. It's not a supplementary service. So we are advocating for inclusion or recruitment of more nutritionists into the system to be able to serve Kenya effectively on that pillar, on healthcare service delivery. And on the health information systems, more nutrition indicators should be included in the reporting structure so that we continue making decisions. A lot of researches are going on, and very advanced indicators have been proven to be able to show the direction in terms of output. Optimization of health records for nutrition care, collection of data, and the data analysis should be improved by expanding indicators within our systems, current systems for reporting. And this will enhance direct information and hands-on for government to continue making decisions. As at we talk, the indicators that are still being reported are still putting us at the level where we are just a supplementary service. I know a number of them have not been included. So in conclusion, nutrition and dietetics services and products are key in strengthening health systems and not subsidiary. Integrating nutrition and dietetics services into the health systems will enhance efficiency and effectiveness, reduce the costs of healthcare, which is actually critical for us, enhanced equity and access to service delivery in primary healthcare, which is very critical. So what are some of the key recommendations that we are making? I've heard about 4 recommendations, which are key, and this should actually go to our government. I wish the cabinet secretary was here. We are saying that we establish and incorporate, establish and operationalize nutrition and dietetics services delivery department in all healthcare facilities. And I mean all, from level 1 to level 6. The second recommendation, engage and deploy nutritionists and dietitians to match the service needs as per the norms and standards according to our Public Service Commission. Because this has already been done by KNDI, and in that we required 60,000 nutritionists. Dr. Keo will confirm that, which is already known by the government. So they can start even from that level. The third recommendation here is that include nutrition services and products into Social Health Authority reimbursable items, so that when nutritionists are giving their services, just like surgeries, just like consultants, these have to be reimbursed within the healthcare system. The fourth recommendation, establish and operationalize the Directorate of Nutrition and Dietetics Services for efficient and effective leadership and governance as a pillar in strengthening healthcare. So we cannot remain as a unit in the Ministry of Health. This is just requiring operationalization because it is already existing in the law. And that will lead to strengthening that pillar. And even in our counties, instead of having nutrition coordinators, we need to have directors of nutrition services. In fact, some counties have already operationalized this. I don't know why we still have nutrition coordinators. Because what that means is allocation of funds, and you become a unit for costs. A center, it's called the cost center in the ministry. A coordinator does not have a cost center. Then finally, advocate for enhanced line budget for the directorates, either at national, at county. And thank you very much.
Let's give a more organized round of applause for Professor NGUKA for the good work that he's done. Thank you very much, Professor NGUKA. Quite enlightening and speaking to the concerns that can actually build or bring nutrition to where it actually belongs. At this moment, I want to invite Dr. Okeyo for a rider alongside that before we get to the comments and question section.
Thank you, and thank you, Prof. One thing I know is that normally Prof keynote comes at the end of our conferences, and he has one duty to analyze the conference scientific processes, including the presentations, and have a night to summarize what we need, which then becomes a resolution. And still, we have indicated that our professionals should write one word that they think is key in nutrition strengthening within the health system. One word. So even if you just say governance, it's just governance. If you say technical, it's just technical. If you say capacity building, it's just capacity building. So by the time you finish, together with what Prof has just presented, we'll have what we call a declaration. And after that, we also want to come up with key resolutions that needs to go as a brief to the Ministry of Health, that is the government. We are hoping that the CS will come, and if he doesn't come because of the schedules, as I've communicated, we still have a role to package what we have and present it on his desk. And as I can tell you, all these are going to reach his desk by tomorrow. So, Professor, thank you very much for good work, because you have summarized many things. We just add and it becomes a resolution. And the emphasis is very simple. Nutrition must be given a position that it deserves in the health sector as envisaged in the Act. And no one can change the Act. If the law says we must have director nutrition services, must be director with power and cannot be under another director who is a medical doctor. It is impossible. So thank you very much.
Thank you very much, Bwana CEO, for that important rider. And of course, this kind of cuts the path that this conference shall culminate in resolutions that shall reach the Ministry of Health. And we pray that this will definitely have the visibility and recognition that nutrition actually deserves. At this moment, we have about 15 minutes of responses and questions. And I will ask that for anybody who is making their comments, be as conscious about time as you can be, and be as straight to the point as you actually see we need. I'm seeing Arthur, my friend from Nakuru, level 5. Arthur, straight to the point as you always are.
Thank you. I want to give my appreciation to Daktari there. Yeah, my heart. And that is one of the topics that made me come here. And I'm happy to see on the recommendations that have been done. And I'm happy letter to Dr. Okeo, and I've seen it has been covered. One of the things I want to add on what you have said is that to ask for our things to be included in SHA, we need to make sure that in inpatient, especially in inpatient for nutrition, is incorporated in KDHIS in terms of reporting. We have a problem that if you go to KDHIS, the things you are only reporting that has only done in community level 1, level 2, and 3. And that makes a problem for the there are. So my carry-on call is that there are tools that were developed by the Ministry of Health for Nutrition for inpatient. We make sure we have a reporting mechanism so that we can know how are being fed through tube feeding, how many are being given parenteral and enteral, so that alleviate the HRH. And also my second addition is to the partners. The partners have concentrated more on community and have forgotten the curative path in hospitals. We want to urge the KNDI, if we can have supervision, let's start with county referral hospitals. What enforce ring-fencing of nutritional budget in hospitals. That is my clarion call. It's not more, but I'm happy if you can. You made a promise that will not finish your chairmanship before making sure that SHA, that nutritional product, are included in SHA. We are holding that one. Thank you.
Thank you very much, Arthur. You can feel the passion that flows from that man as he speaks. I'm sure when you're talking about KDHS, you're talking about KHIS, right? Yes, thank you very much. Dr. Charlo? I know, Dr. you are very brief and straight to the point, succinct actually.
I will try.
Yes.
Yes, thank you very much, Professor, for that very great presentation. I think you've captured all our problems in those 15 minutes or so, 10 or so minutes. Mine are more like thinking loudly. And I will start with the governance. Not just at the national level. I'm looking at from the top to the bottom, where nutrition at the community level is being handled by the CHPs. And if I just pick one aspect of what the CHPs are doing at the community level, the BFCI, the curriculum for BFCI is a very complicated curriculum, and these people are supposed to go through this, I think, is it for a week plus 2 weeks, and then they are being trained by practically everybody. The malaria guys are using these people to do malaria campaigns, everything at the community level. And KNDI, we have a set of professionals called community nutritionists. In my opinion, those are the guys who should be doing nutrition at the community level. Because when you interact with those people at the community level, there's a lot of misinformation that is being passed on from household to household and from person to person. And you know, at that level, they say, I was told. What I was told is what passes on. That is one. I would like to comment about a category. You mentioned about preventive nutrition and a category of our population that is now getting some mileage, but in my opinion, not enough. The school children. For those of us who do research in schools, one of the things you notice is that it is very rare to get a school that is giving children more than 4 food groups. The norm is 2 to 3. Breakfast, porridge, lunch, rice and beans, supper, githeri. And that is repeated 7 days a week, and our children are in school. How many, is it 9 to 10 months of the year they are in school? So for me, that is a point. And these are the guys who are growing. You know, they're at that stage where they have all these extra nutritional needs. So that is something I think even in our advocacy, we need to be louder. We need to be louder, and we have more and more children there. Finally, about SHA and insurance coverage in general, I think SHA has been covered. But I ask myself, even the private insurers, they will give you a list of consultants, gynecologist, pediatrician. Do they have nutrition consultants there? And are we missing something? Thank you.
Thank you very much, Doc. Of course, you know that I have a soft spot for Daktari, but that's not the point. Thank you very much for adding, Daktari, the three aspects you talked about: community engagement in nutrition, school nutrition, and the use of nutritionists in the lists that are provided by insurance as part of consultation. I take those as comments, or do I give Prof a moment to respond to these two specific comments? Prof, if you can be brief so that we don't chew so much into the rest of the day's work.
Okay. Very, very brief. Thank you very much, colleagues. And I'm happy, Dr. Kello, you've mentioned a very important point that's close to my heart, and that is school children feeding. I want to agree that dietary diversity and even dietary variety of school foods, for that matter, is actually very low. And it is something that we need to be very loud about. It is actually targeted by budget, and Ministry of Education, as you may know, usually think that just keeping the children there and filling their stomach is just the in thing, and then they are done. This has been contributed to by a systemic, I don't know whether it is, it has been a problem that was created by our colonizers or something. I just don't understand. But this classification that was done at primary school level of energy, was it energy giving food, or they call it carbohydrate, protein, and vitamin, 3 classes of food, they are done. This has contributed to the Ministry of Education. And even today, they think that if they have such kind of a monotonous diet, according to them, they are okay. So I want to agree with you that it's one of the things that we need to pick up. And Martha, in your capacity now, not as an I, but as the chair of SUN movement, as the chair, because you, under that, you have so many organizations. I think this is something that we need to talk about, because government listens to people. They listen to lots of noises. If the noise does not come, then they think there is no issue. So, and the more the noise, the better for their ears. I think it is something that we will take from this side as a regulator, but also it is something that needs to come from our stakeholders so that we push for even additional food items, particularly fruits. They provide some vegetables, and according to them, the vegetables should serve as fruits as well. It's lack of, it's ignorance. They don't understand. So I think something will need to be done. As for the issue of consultants, the other issue I've covered, the issue of expanding the health information system. It is covered in the last pillar, the 6th pillar, properly. So that it will go as a resolution. I think in general, let's combine efforts in all our areas to be able to push for this implementation of the resolution that we have made. Thank you very much.
Thank you very much, Prof. Just one last comment before we go